This is an introduction to advanced cardiac life support. The advanced cardiac life support approach to cardiac care, cardiac patients, cardiac resuscitation that's been used by the American Heart Association for many years. This has been around since the 70s. 1974 is when the first guidelines were published. And this is an era when defibrillators weighed 75 pounds and nurses were required to wear dresses and cute little white hats. Things have changed a lot, and ACLS has changed along with it. In this video, I'm going to try to go over the basics of understanding the algorithm approach, the structure, the evidence behind it, and the reasons and the way that we use ACLS effectively in cardiac care. Some of the keys to mastering ACLS is recognizing that everything is built around algorithms rather. Algorithms are a simplistic way to spell out step-by-step instructions of what's coming, what comes next. If this, then do that. It's a simplified way to view things that is very helpful for memorization and for putting things in context. But the algorithms come with a lot of caveats, because you can't possibly, in little tiny boxes, spell out all the details that are involved in the decision-making of cardiac care, and so you have to get familiar with those additional pieces of information and the rest of it. ACLS is evidence-based, and I have that in quotes on this slide because evidence is mixed, and I'll talk about that in a minute. There's different levels of evidence, and sometimes it's based on expert opinion, which is not really evidence-based, but it's the best we have to go off of. And so we do more and more research every year, both in the US and internationally, looking at the best evidence of what is the most effective, or what are the most effective cardiac treatments. Promising treatments get added to algorithms, sometimes based on limited evidence. That gives us the opportunity to test them out further to determine if they really should be in the algorithms. And that research that we do increases the likelihood that we're going to change things in the future and hopefully improve our care. The other thing that's important to recognize about the protocols and about the algorithm format is that not every recommendation on a given algorithm is going to be practical or applicable to every patient. You have to put it into context. You have to make sure that this simplified algorithm is working appropriately for the patient that you're taking care of. A couple of keys to understanding ACLS. Number one is that these are just guidelines. These are here to help us understand what is likely to be a good path of treatment, and they give us a range of treatment options. Every one of those ACLS treatments are rated, and I'll talk about this in a bit, that there's a class of recommendation, class 1 being the strongest recommendation, goes down from there. There's also different levels of evidence for the different recommendations that we have. And so we can look at those and understand whether the things that we're doing are well proven to be effective or perhaps not so well proven at this point. These are based on international research and a wide scope of practice. One set of recommendations is designed, this one algorithm is designed for everyone from BLS, basic life support providers, up through cardiologists. And so obviously it's intentionally simplified to work for a broad range of providers, but depending on your role and how you use the algorithms will determine how much additional information you need to have a solid understanding of. The ACLS algorithms themselves have a flowchart approach, as I said, if this, do that kind of approach, and they're intentionally simplistic. That makes them excellent as study aids, as reminders, as a quick reference that you can use during care, but they're not comprehensive. They are never intended to be a description on that one page of everything that you would do for a patient. They also are not intended to limit you. Nothing says that just because a treatment doesn't show up on that one-page tachycardia algorithm that you can't use other things to treat your tachycardia patient. Another key to the algorithms is we need to be very careful that the algorithm that we're using is appropriate for the patient that we're treating. It's easy to jump to conclusions, not do a comprehensive assessment, and possibly start treating people based on an algorithm. Tachycardia is the classic example that we'll talk about in a minute, that oftentimes tachycardia is a symptom, not the primary problem. Using the algorithm approach is all built around, and all of AHA's, ACLS, PALS, all of these courses are really built around a team concept. And within that, every team member has a specific role or responsibility. In EMS, we've taken this a step further, and we really focus on a pit crew approach where those roles are very specifically defined and carried out consistently. But for testing purposes for ACLS, we want the team leader to be calling the shots. Whoever is in that role of team leader is making decisions about the next treatment, the next intervention, monitoring the team, and that sort of thing. So in your ACLS course and in your ACLS test, when you're the team leader, you are expected to make the majority of the decisions. However, in the reality of cardiac resuscitation care, everyone is involved, and everyone should be involved. Everyone should have an active part in making sure the resuscitation flows smoothly and that the right things are being done. The roles that we define are a few key things, and for right now, in the purposes of this, I will just put it in two categories: the team leader and the team members. The team leader is a person that's at the foot, ideally, where you can see everything that's going on and monitor the activities of everyone. Or if you have limited personnel, limited resources, it may make sense for that person to be at the monitor defibrillator, where they can see the rhythms, be in a position to deliver shocks if needed, but be a little less hands-on than the person who is doing compressions or the person who is managing the airway. It's important that the team leader be composed. They need to be decisive. They need to communicate. They need to communicate the rhythms they're seeing, the observations they make. You need to make sure that the entire team is aware of what is going on with the patient and the decisions that are being made. And as a team leader, you also need to be very open to suggestions. Allow your team to participate. In most settings, your team is made up of a number of medical professionals with a variety of skills and experience, and they should be contributing to appropriate decision-making in a resuscitation. The team members, all those support members, need to keep perspective on patient assessment findings, need to be looking for vital signs after rhythm changes, checking for pulses if there's been a change in rhythm, advising of any completion of procedures. So if the team leader is asking that IV established, not only should you as a team member establish that IV, you should say out loud to your team leader in a way that the entire team hears that I now have an IV established. That way they know they're ready to start thinking about drug administration. Everything needs to be communicated clearly, including our assessment findings. So if you notice a change, that there is a pulse, there isn't a pulse, if you gather vital signs, you need to share those with the team, and especially with the team leader, in order to make sure that everyone involved in the resuscitation has a clear and consistent idea about what is going on and what needs to happen next. I'm going to break down the ACLS algorithms into a couple of really simplistic ways of looking at it. We basically have one algorithm, a one-page description of how we manage dead people. These are people who are pulseless, patients who are pulseless. And within that pulseless category, we have two categories or two branches. One is shockable. The only shockable rhythms in ACLS are ventricular fibrillation or ventricular tachycardia without a pulse. In those cases, we go down the shockable algorithm side of the algorithm, the pulseless cardiac arrest algorithm, and the first priority is shocking these patients. If, on the other hand, they have a non-shockable rhythm, this would be asystole or pulseless electrical activity, meaning we see electrical activity on the monitor, but it's not producing a pulse. In that case, we're going to follow a different list of priorities in how we attempt to resuscitate those patients. And the main difference is it does not include electricity. I have YouTube videos that I've created that go over the treatment algorithms specifically for both shockable and non-shockable rhythms, and you're welcome to watch those as well. ACLS also has several algorithms for live patients. The ones that we use predominantly and that we focus on in the ACLS course are these four: acute coronary syndromes, bradycardia, tachycardia, and post-cardiac arrest care. Acute coronary syndromes is a catch-all category that encompasses patients who we suspect of having an acute coronary event. The classic is chest pain, of course, but it can present in a variety of different ways, and it's up to us as providers to use the top half of this algorithm, the top green boxes, to determine and help solidify whether or not we think this is a cardiac event. And so those two boxes are really focused on good, thorough assessment. One thing that should be emphasized is that the 12-lead ECG, which is the third bullet item on this first green box, really should be a high priority, and especially should be acquired before we start interventions, because some interventions like nitroglycerin may change ST elevation, may hide the evidence of an MI without actually correcting the problem. So we want to do that 12-lead early. And then the rest of those green boxes are about a thorough history, a good physical assessment, and supportive care. If we suspect this is an acute coronary event, then aspirin is appropriate, nitroglycerin is appropriate as long as they have a blood pressure that can support it, and if that's not successful, morphine can be considered for pain management as well. The lower half of the acute coronary syndrome algorithm is where we get into the meat of our decision making of what happens next. And essentially we're using our 12-lead ECG to put the patient into one of three categories. The first on the left is a STEMI. That means we have ST elevation. We have evidence in 2 or more contiguous leads that this patient is having an infarct or is at risk of infarcting at this time, in which case all of our treatment is focused on opening those obstructed vessels. Ideally, we do that by getting them to a cath lab where a stent can be placed. In some settings, it may be reperfusion therapy by giving a thrombolytic or a fibrinolytic drug, but the goal is to open up the vessel because we know we have strong evidence that the vessel is closed. The far right column is a normal or non-diagnostic ECG. In this case, we don't have evidence from our 12-lead that indicates the patient is having an MI, which lowers the risk of an acute coronary syndrome being an acute problem for them. We are going to still consider admission to an emergency department or consider appropriate treatment, but we don't have the evidence that this patient needs to be part of a cardiac system of care and go to a cath lab. The center column is what we call non-ST elevation acute coronary syndromes. And these are the category where we don't have a normal 12-lead. We also don't have a clearly diagnostic 12-lead. We're somewhere in between. We're on our 12-lead. We're seeing things that make us suspect that this patient has ischemia and is at risk for acute coronary an acute coronary event, an infarct that could worsen. Not all acute MIs present with ST elevation. And so that center column describes the way we're going to manage those patients, essentially to be prepared to take them to a cath lab if the evidence is strong enough to do so. The bradycardia with the pulse, I have a complete video of this on my YouTube channel that talks about bradycardia management. Essentially, the top box is assessment and evaluation and supportive care. And the bottom line is we think this rate is the problem. We think their rate is too slow and we should speed it up. We have 4 options available. We can give the patient atropine, we can use transcutaneous pacing, and if those aren't effective, we can try a dopamine or an epinephrine infusion. Again, if you want the full details of bradycardia, you can go watch that video. The next is adult tachycardia. This is the one that we have to be really careful of. And the first box in the orange box is assess the appropriateness of the clinical condition. And what this means is that if the heart rate is less than 150, it's likely that the heart rate is a symptom of some other problem that needs to be managed. If the heart rate is over 150 and the patient is showing significant signs and symptoms, it's reasonable to assume that the heart rate itself may be what is causing the signs and symptoms. So once we've done that assessment, once we decide this really is a rate problem, then we're going to do something about it. And we have to establish if they're stable or unstable. If they're unstable, we're going to use electricity. If they're stable, we're going to try kinder, gentler methods, such as giving adenosine or a vagal maneuver. And again, a tachycardia algorithm I have outlined in a separate YouTube video that covers this in more detail. And finally, we have ROSC. ROSC stands for Return of Spontaneous Circulation. This is what AHA calls the post-cardiac arrest care algorithm. And essentially, this is when in a cardiac arrest management situation, we have a return of pulses. And when we get to that point, the goal is entirely focused on keeping those pulses once we have them. One of the most important things to do is to pause. Give that heart an opportunity to respond in a productive way. Do not get in a big hurry to shock, to push drugs, to do other things immediately. because the heart needs a little time to improve. And even if what you're seeing is a tachycardia or a bradycardia, if it's producing a pulse, that's significantly better than the pulseless status this patient was in a short time ago. And so we need to give that an opportunity. We're going to manage the airway effectively, we're going to ventilate effectively, and we need to be prepared to give fluids, because often these patients will need a significant amount of fluid in order to maintain an adequate blood pressure. And then we go on to do other continued management, other care, including things like targeted temperature management if you work in a setting where that is an acceptable option and you have the tools in order to do that. And that's essentially cooling the patient's core temperature and keeping them cooled for 24 hours in a very controlled way, which improves neurologic survival. ACLS also has a number of specialized treatment algorithms that go beyond the scope of this video, but just so you know, there's an algorithm for stroke, for specific steps of cardioversion, for managing hypothermic patients, patients who are pregnant and in cardiac arrest, opioid overdose, vascular assist devices, and targeted temperature management that I just mentioned. So as you go through ACLS, depending on your role and the setting where you're going to work, it's important that you understand the ins and outs of all of these various algorithms. A couple things I want to emphasize about using the algorithms. And one of the keys is we need to assess our patient before we jump into an algorithm. I've already alluded to that, but make sure that you're on the right page that fits the patient's condition. A couple of things to remember is we're doing an assessment very quickly from the very start. Is this patient sick or not sick? If they are sick, we're going to stick to those basics on that simplified algorithm page. Manage those initial things that are life threats. That's what that simple one-page design is really intended for. We also need to figure out what started first. Possibilities versus probabilities. Are there chronic issues of this patient that probably have an impact on that presentation? A good example would be patients who take beta blockers for their blood pressure or for another reason will often have a bradycardic rate related to what their body needs at that point. That's not a reflection of a rate problem with their heart. It might just be a reflection of the medications that they're on. So we need to look at some of those underlying things before we jump in. And the rate. As I already mentioned, if it's fast or if it's slow, we need to do enough of an assessment to be confident that we know whether the rate is causing the symptoms or the rate is a symptom of some other problem, like hypovolemia, like some other form of shock. Patient may be very tachycardic because they're sick and they need that tachycardia to maintain an adequate blood pressure. In that case, trying to slow down the rate would be harmful, not helpful. The criteria that AHA uses to define a patient as either sick or not sick, in ACLS terminology we see stable or unstable. The criteria we use to decide if they're unstable is a new onset of symptoms, hypotension, an absence of a pulse, clearly, new onset of chest pain, dyspnea, or changes in level of consciousness. Now, if you only have one of these, you may, as a provider, decide that I don't really feel like this patient's unstable just because they have a little bit of chest pain. But if you have a patient who has chest pain, shortness of breath, and is confused, that is clearly an unstable patient. And we need to pay attention to those clues as we move down the algorithm and decide on our treatment choices. I want to talk a little bit about interventions and treatments in ACLS, and specifically the classes and evidence, and how these things get incorporated into our ACLS guidelines. All of the therapies that are available to us under ACLS are categorized to help us to select appropriate treatments, to make good decisions about the strength or weakness of any recommendation, to understand what's more likely to be helpful to our patient. And the way the American Heart Association does that is they start by looking at quality of evidence. The best evidence is level A, which comes from robust studies, more than one random controlled trial, good, strong evidence that a particular drug, procedure, intervention has been tested, has been used, has been shown to be effective. That's a high standard in emergency medicine, but where we have it, it gives us very strong confidence that this is a good thing to do. Level B also involves studies, but often they may be randomized studies that are a little less robust, or they may be non-randomized studies. So there are studies being done, there's data being collected, it just doesn't have the same level of rigor as the ones that meet that level A categorization. The next is level C, and this is broken into two separate levels. Level CLD stands for limited data, and that means, yeah, there's some studies, but there may be limitations. There may be significant limitations to those studies. There may be things that make it difficult to know if it applies in certain settings, that sort of thing. And then the lowest level of evidence rating is EO, which is expert opinion. Basically, we have a lot of smart people, a lot of cardiologists, emergency physicians, others who have compiled their experience and their knowledge of emergency medicine and have come to a consensus of what is a reasonable and appropriate thing to do, but it's based on just that. It's based on experience and opinion, not actual evidence. When we look at the classifications, based in part on the level of evidence as well as some other factors, the American Heart Association classifies everything into one of these categories. The first is Class 1, a strong recommendation. Class 1 recommendations are things that are believed to clearly have more benefit than risk. These are recommended, they're considered useful, effective, beneficial, and these are the things we should do. Class 2, moderate, there's two portions of Class 2. Class 2 moderate means the benefit still outweighs the risk. It's described as being reasonable, can be useful, can be effective, can be beneficial. And this is a little less strong of a recommendation than a Class 1, obviously. If you move on to Class 2B, now they're describing this as weak, that the benefit is hopefully greater than or possibly equal to the risk of doing this particular thing, whether that's a medication or an intervention. This may be reasonable, it may be considered, its usefulness is really unknown or unclear, and so a Class 2B is a weak recommendation. Class 3 are the things that aren't recommended, and they even break this down into two categories. The first is that it's not recommended, often because there's no benefit to it, or the benefit is equal to the risk. There may be a risk, there may be a benefit, but they really cancel each other out. And then the final one is Class 3 harm. These are things that we've identified are dangerous. These are things that we should not do for our patients. These are circumstances or situations that shouldn't be applied. You may have certain medications that are classified in different classifications depending on the rhythm or the situation that you're dealing with. So it's important to recognize that there isn't just a one-size-fits-all classification for every intervention. Those classifications are specific to what we're considering using that intervention for. What's interesting is we look at the levels of evidence and the classes of recommendation that actually play out in the recommendations in the guidelines. The most recent published guidelines are the 2020 AHA guidelines. There are 491 of those recommendations, and you notice that on the left we see that about a third of them are Class 1 considered a good idea, something we should do. Class 2A gets into that, probably beneficial. Class 2B, it's kind of a roll of the dice whether that's going to be beneficial or not. So there's only about a third or maybe two-thirds of these that we recommend fairly strongly as things to do. What's more surprising to most people is when you look at the right. We said that level 1 or level A evidence was the best. Only 1% of those 491 recommendations have level A evidence to back them up. About a third of our recommendations are down in that level B category, meaning there's some studies, but they're not as robust as the level A. And about a half of our total recommendations are based on limited data. And another 17% are just opinion. They are based on expert opinion. And so what's important to keep in mind and important to recognize why ACLS guidelines change on a regular basis is that as more evidence is accumulated, as more evidence comes to light, as we build up the high level of evidences, on the right, it's going to change what that graph looks like on the left. And oftentimes things we thought were very effective years ago, we know now are not so good. In closing, I want to say that it's important that you read the guidelines. I mentioned that the algorithms are a very simplistic view. There are footnotes and additional information attached to those guidelines, which is also very limited and simplified. But if you go to cpr.heart.org, you can download the current guidelines, and there's hundreds of pages of very detailed guidelines for each one of these components, each one of these treatments and interventions. And it's important to get into the guidelines to really understand cardiac care. That's where the meat of it is. That's the data and the information that backs up the choices we make. The algorithms are a great tool to help keep us on track, but if you want to be a good, competent cardiac care provider, you need to understand the rationale behind them and the research behind them in order to do this more effectively. Good news is that cardiac care is actually much simpler now than it was in the past. It's more research-based than it was in the past. We keep getting better at this, and the outcomes for our patients keep improving. So it's worth the time, it's worth the effort, and I encourage you to spend some time getting familiar with this, especially if you're just getting ready to take an ACLS class. Thank you.